Um, Hello, good afternoon. We are very happy to be here once again. I'm very grateful with Microbiome Labs for the opportunity. Thank you all for being here learning with us also. I leave you with Patricia Madrigal, Dra.Patricia, who will introduce you to Kiran. And thank you again for being here.
Bueno, hola a todos. Voy a dar la introducción de Kiran en español. Para los que no lo conocen, Kiran es un microbiólogo que ha estado involucrado en todo el tema de la suplementación y de la nutrición desde hace 16 años. Pues él tiene una gran formación en el área de la microbiología y medicina molecular y ha estado involucrado en muchísima investigación científica. También tiene un posgrado en lo que es investigación de biología molecular y virología. Kiran fundó una compañía que se llama Clinical Research Organization, donde él pues ha llevado a cabo cerca de 12 estudios clínicos en nutrición humana. También es el cofundador de New Science Trading, que es una compañía que se dedica a la nutrición, a la investigación y al desarrollo de tecnología en esta área. Y él es cofundador de Microbiome Labs y también es el jefe científico de esta empresa. Es muy reconocido en el área del microbioma humano y ha participado en muchísimas conferencias en esta área. Y realmente, Kiran, bueno, ya estás varias veces que nos acompaña y es siempre un honor. Kiran Krishnan is a research microbiologist and has been involved in the dietary supplement and nutrition market for the past 16 years. He is in the field of molecular medicine and microbiology and also has a postgraduate research in molecular biology and virology. He established a clinical research organization where he designed and conduct over a dozen human clinical trials in human nutrition. He's the co-founder and partner in New Science Trading, a nutritional technology development, research, and marketing company in the U.S. dietary supplement and medical food market. And he's also the co-founder of Microbiome Labs and also the Chief Scientific Officer of this company. He's a frequent lecturer on the Human Microbiome Medical and Nutrition Conference. So, okay, many things more, but it's not easy to say all that. So thank you for being here, Kiran, today. And I'm very happy because I know that today we are going to learn a lot about this vitamin that is not very known for us. So thank you, Kiran. And
yes.
When you want, you can share. Okay.
Can I share the screen? Okay. Let me go ahead and do that.
Yes. Okay. Let me see because. Yes. Now you can share your screen.
Okay, great. So let me bring this up. And before I jump into the lecture, Patricia, Karen, thank you so much for having me. It's a pleasure to be able to do this, in part because for me, and hopefully by the end of the presentation, you'll see the same, that this is arguably one of the most important nutrients that we need to be getting people to take. You know, you'll start to see why I consider this nutrient an omnipresent nutrient, meaning it is present in all kinds of systems within the body and conducting very critical functions in all of those systems. And a deficiency in this nutrient is highly detrimental in a number of ways, right? So we'll go through all of that with the science and the research that's available. Then we'll also talk about some of the new discoveries that we have made in studying this nutrient for the last 20 years almost. There's a lot of work on vitamin K2, K27. If you go on PubMed, you'll find thousands of published studies, and they cover a number of different topics. I'll cover many of those today, but then we've also made our own discoveries in other areas where it functions. like normal, I'll switch off my camera just to ensure that the quality of the transmission comes through well. And then after that, I'm more than happy to turn it back on in order to do the Q&A session. So let's jump into this. Vitamin K2 and K27, and I'll distinguish the different forms of vitamin K. But first, the vitamin K itself was discovered in 1929 by a German researcher, and the German researcher's name is Heinrich Damm. And the reason it was named vitamin K was because the word coagulation starts with a K in German. And it is a fat-soluble vitamin along with A, D, and E. And the initial discovery of vitamin K was in the coagulation pathways. It activates K-dependent proteins, so VKDs, vitamin K-dependent proteins. And the current RDI for vitamin K is typically based on what we call K1, which is 90 to 120 micrograms a day. And that's typically for preventing blood clotting, for preventing excessive bleeding and to initiate normal homeostatic blood clotting, right? So almost everything that's out there in terms of RDI and what's put in multivitamins and so on is based on vitamin K1, and that's based on preventing excessive bleeding and maintaining homeostatic blood clotting. That's 90 to 120 micrograms per day. Now, the most natural sources of vitamin K, and when we're talking about K2 in particular, we've got menaquinone. Menaquinone is a form of vitamin K that's considered vitamin K2. So phylloquinone is K1, but menaquinone is K2. You can find some menaquinone in fermented dairy products. So in Northern Europe, there's certain fermented cheeses that have a decent amount of vitamin K2. Some fermented dairy beverages like kefir will have some amount of vitamin K2, but it has to be a true fermentation. The commercial products that you find in grocery stores, kefirs and all that, just don't have enough vitamin K2. And then, as I've been talking about, that's important to distinguish vitamin K2 from K1, which is phylloquinone, and K1 comes from leafy green vegetables, right? So K1 is the source. The source of K1 comes from leafy green vegetables, and its main function is in the liver, in the coagulation cascade. And again, all of the RDIs that are related to vitamin K are based on K1 and its function in coagulation. It's not based on K2. K1 is the hepatic form of vitamin K. K2 is the extrahepatic form. So K2 is the type of vitamin K that's found in circulation. And the richest natural source of vitamin K2 from food is a food called natto. It's a fermented soybean food from Japan. And there are regions of Japan that eat a lot of natto every morning for breakfast. And then there are regions of Japan that eat almost no natto at all. And that's been interesting because they've been able to do some really good epidemiological studies in Japan itself based on the consumption of natto, which is very, very rich in vitamin K2. I'll be talking about dosing later on, but just keep this in mind that the natural dose of vitamin K2 in natto can be upwards of 600 to 700 micrograms per meal, per 50 grams of natto. 50 grams is about the size of the meal that they typically eat of this fermented soybean, right? And this type of K2 that's produced from fermentation, the naturally produced vitamin K2 is called K27. Or you'll often see it abbreviated MK7. And the reason for the MK is because it's the menaquinone 7. So you'll see it as MK7 or K27. So it's important to remember that because there's another form of K2 that you'll run into in the marketplace called MK4 or K24. It's a shorter side chain length, but in certain foods, you do find K24 as natural source. In particular, things like emu oil, you'll find some K24. In organ meat, so if you're eating liver or brain, you do find some K24. But in the supplement world, K24 is synthetic because there's no really rich form, a natural form of K2-4 that can be harvested for supplements. It just doesn't, it's just not produced at high concentrations like K2-7 is, because K2-7 is produced from bacteria during fermentation. So hopefully that's clear, but we'll emphasize that a little bit later on as well. In general, over the last several decades, this is what's been identified as the tissues that need vitamin K, right? So the first one is the blood clotting factors. And as I mentioned, that's vitamin K1. And all of this is happening in the liver. This is with thrombin activation and then moving down the clotting cascade. And again, that's K1, and that's happening in the liver. Extrahepatically, or outside of the liver, vitamin K2 is required for bones, for a protein called osteocalcin. I'll describe what that is in a few slides. And then in addition to that, K2 is also required in the arteries for another protein called matrix GLA protein, right? Those two things become extremely important as we go through this presentation. So we've got osteocalcin in the bone, matrix GLA protein in the arteries. Now, the basic biochemical function of vitamin K2 is it conducts something called carboxylation. So it initiates a carboxylation reaction where you take an inactive protein, whether it's osteocalcin in the bone or matrix GLA protein in the arteries, they are always released in inactive form. So you take the inactive form of those proteins, K2 helps carboxylate them into their active form. So K2's role is to activate these vitamin K dependent or vitamin K2 dependent proteins that are found throughout the body. Keep in mind that we'll be talking a lot about osteocalcin and matrix GLA protein. I'll mention a couple others during the talk as well, but there have been about 12 identified vitamin K2 dependent proteins in the body that conduct really important function that require vitamin K2 in order to activate them, right? Now, when you look at abbreviations in research, when you see the osteocalcin is abbreviated as OC, obviously for osteocalcin, and then matrix GLA protein, which is the one in the arteries, is abbreviated as MGP. Research studies on K2 will talk about UC-OC, or under carboxylated osteocalcin, or UC-MGP, or under carboxylated matrix GLA protein. That's the inactive form of those proteins. When they get activated by vitamin K2 through this carboxylase reaction, then they are described as COC, which is carboxylated osteocalcin, or CMGP, carboxylated MGP. So this is the active form. This is the inactive form. Keep that in mind because you'll see it in the research as I show you the studies, but that's vitamin K dependent proteins. So first let's start about talk about the role of vitamin K2 in bone and in bone health. And this is one of the more well-studied areas of vitamin K2, and it's been studied for almost 40 years, I would say. And there's hundreds upon hundreds of huge published studies around vitamin K2 and bone health. And again, all of it centers around osteocalcin. So what is osteocalcin? Well, osteocalcin is, of course, a vitamin K and K2 dependent protein. It's synthesized by osteoblastic cells. So everybody knows that bone building cells are called osteoblastic cells. The question is, how do they build bone? Well, the key function that they have is the production and release of osteocalcin. But of course, remember that osteocalcin is always released by osteoblastic cells in its inactive form, in the UC-OC form, the undercarboxylated form. But osteocalcin, once activated, actually provides the matrix upon which calcium crystallizes. So without osteocalcin, you cannot stick calcium on the bone. You cannot form the bone matrix and the crystalline structures that are required to provide bone both the strength and the structure that it naturally has. So osteocalcin is critical for bone building, released by osteoblastic cells, must be activated by vitamin K2. Osteocalcin is said to be the glue that holds calcium in the bone. It gives it structure and order to the bone tissue. Without it, bone would be fragile and easily broken. So bone wouldn't have that characteristic honeycomb kind of structure that provides its strength and rigidity without a lot of weight. So bone is light and yet really strong. But osteocalcin is a key component to that. And of course, as I mentioned, vitamin K2 activates osteocalcin through that carboxylation process. And without carboxylating osteocalcin, calcium cannot be properly utilized for bone structure. Right, so you can take all the calcium in the world. If your osteocalcin is not activated by vitamin K2, there's no sticking that calcium to the bone. There's no formation of osteogenesis. There's no building of the bone. So it's not calcium in itself as a supplement that drives bone building. It's the work of osteocalcin, and osteocalcin requires vitamin K2 in order to do the work. One of the first studies that really illustrated the role of vitamin K2 in terms of bone strength and is an epidemiological study looking at fracture rates as it relates to vitamin K2 intake. This was a study published in 2001, and they looked at Japanese women, especially Eastern Japanese women, and Eastern Japanese women have around 5.26 nanograms per ml level of MK7 or K27 in their circulation. And corresponding to that, you see a really low amount of fracture rate among these women. And these were perimenopausal and postmenopausal women, right? So when you have higher amounts of vitamin K27 in your serum, you tend to have very low levels of fracture rate in peri and postmenopausal women. Now in Western part of Japan, where they eat less natto, right? So you see here about almost a fourth of the concentration of K27 in the in circulation in these women, you see a dramatically increased amount of fractures in perimenopausal and postmenopausal women. So there's a direct correlation here. But then here are these women over here who have a much higher fracture rate, measurably higher fracture rate. And those are women in Britain who have almost no vitamin K2 in their circulation at all, because of course they don't eat natto, right? So that is the big difference. They don't have a natural source of vitamin K2 that they take in through their diet. And so you see it in the level of circulating vitamin K2, and then you also see it, of course, in the fracture rate itself. And so high natto consumption means high vitamin K2 blood levels and decreased hip fracture rates. Vitamin K2 levels are inversely related to hip fracture rates. And there's a number of studies that have shown this. And this was one of the first studies that illustrated that. More K2, less hip fracture. We all know once somebody gets a hip fracture, that really becomes a significant issue that causes a whole bunch of other risk factors, starting with the immobility of having a hip fracture, the hospitalizations, the surgeries that are involved, and so on. It becomes a mess when they start going down that road. And really, all you need to reduce hip fracture rates by this significant amount is by having intake of vitamin K27, right? Very significant. Other studies similar to that, so Kaneka, this one showed the high consumption of MK7 levels from natto resulted in better levels of activated osteocalcin, so that activation of osteocalcin reduced the risk of fracture. So again, further validation that you need K2 to activate osteocalcin, which then protects the bone and makes the bone stronger. There was a follow-up study in 2006 that showed that natto consumption, again, the richest natural source of vitamin K2, helps prevent the development of osteoporosis. Further studies, like in 2008, showed that the better the vitamin K status was attributed to natto resulted in the reduction of hip fractures as well. So there's been a number of epidemiological longitudinal studies looking at the intake of K2 through natto, the activation of osteocalcin, and then hip fracture rate, right? So starts to become quite clear. But there's also lots of studies on osteocalcin itself, where they looked at, and this is one study where they looked at undercarboxylated osteocalcin, so the inactive form is inversely correlated with BMD, right? So if this is high, BMD is low. If this is low, BMD tends to be high. Same thing, inversely correlated with BMD, also verified in a separate study. This study right here showed that serum undercarboxylated osteocalcin levels predicts hip fracture rates. Serum undercarboxylated undercarboxylated osteocalcin predicts hip fracture rates as well. High levels of undercarboxylated osteocalcin creates a 6-fold increase in hip fracture rates, right? We're not talking about a 20% increase, 50% increase, or even 100% increase, a 6-fold increase in hip fracture rates. That is really, really significant. There's been studies on this in Japan that shows that adequate intake of vitamin K2 reduce hip fractures by over 90%. Right, so this is very, very significant and very measurable. And you saw that in the epidemiological study comparing Eastern Japan to British women. That is more than a 6-fold increase in hip fracture rate. So lots and lots of studies verifying the same thing. So there's no doubt, you know, that vitamin K27 is absolutely critical for bone health, bone strength, preventing osteoporosis, preventing hip fractures, and so on. And we know osteoporosis, hip fractures are a major driver of morbidity and mortality in an aging population, especially in perimenopausal and postmenopausal women. The other area where vitamin K27 has been really well demonstrated to play an important role is in cardiovascular health, right? And in vascular health in general. So let's go through that a little bit. We just went over osteoporosis. Let's talk about cardiovascular disease. One of the things that became clear in the early 2000s, and this is in looking at all kinds of risk factors like cholesterol, high blood pressure, C-reactive protein, and so on, the thing that really predicts cardiovascular mortality is calcium, right? Or calcification level in the arteries. That is really the best predictor of mortality. And it became very clear, as is published in the New England Journal of Medicine in 2000, according to multivariate analysis, only the extent of aortic valve calcification was an independent predictor of outcome, whereas age, sex, and the presence of or absence of coronary artery disease, hypertension, diabetes, hypercholesterolemia were not. Right? So remember, 50% of people who have heart attacks still have normal cholesterol levels. Not everybody, it's less than 40% of people that have heart attacks have hypertension. So all of those things that we know of as risk factors surrounding cardiovascular events, cardiovascular mortality, are not predictive necessarily of cardiovascular disease. The only one that was independently a predictor of cardiovascular disease is calcification, right? So you see here with this study what they showed, no or mild calcification, mortality rates were relatively low and normal, but the moment you get moderate or severe calcification, mortality rates in years drops dramatically. So calcium in the arteries, calcium in the aortic valve, calcification of that soft tissue is the biggest driver of cardiovascular mortality. And as you already know, K2 plays a significant role in calcium movement in the bone. Now let's look at calcium movement in K2 in the arteries. And it does that through something called matrix GLA protein. Matrix GLA protein, when activated, is the only known inhibitor of arterial calcification. It's a protein whose singular job so far, as discovered, is to remove calcium from the arteries and soft tissue. Right? That's a huge, huge, important job for this singular protein. Its job is to prevent calcification and osteogenesis on soft tissues like your arteries, like your aortic valve, and so on. And MGP is a vitamin K2 dependent protein, right? And so other studies have shown, here's a cross-section of an artery. And what they've shown is when they do a staining for inactive MGP, so remember that will be the undercarboxylated MGP, and you stain the same tissue using a Van Casa staining for calcification, you see the same overlapping regions where inactive MGP has a bunch of calcium deposition as well. Other studies, this was from 3 donors, that had either atherosclerotic aortic areas and then healthy aorta. What they found is that when you look at the tissue samples, the healthy aorta had high levels of vitamin K2, but the atherosclerotic aorta had very low levels of vitamin K2. K1 did not play a role in this at all. It was all about the amount of K2 and how healthy that tissue looked, right? So those were initial pathology types of studies. They're not large-scale population studies. So let's look at bigger, more important studies. This might give us a mechanism, but let's look at outcome in general. One of the most significant studies is something called the Rotterdam Study. This study was looking at the association of dietary intake of K1, remember from leafy green vegetables, the hepatic form of vitamin K functioning in coagulation, and then K2, which is the extrahepatic version. They were looking at things like aortic calcification, CVD, and total death. It was a cross-sectional analysis in healthy adults, 4,807 men and women aged 55 and older, 10-year follow-up, so longitudinal study. And the measurements, the main measurements were calcification, and then another endpoint of mortality or death. Here's what they showed. When you consume daily at least 45 micrograms of vitamin K2, in this case, through the diet, they were measuring it. This is in Northern Europe, so they're looking at cheese intake and all that had a specific amount of vitamin K2. They showed a 50% reduction in arterial calcification. Remember, arterial calcification is the #1 risk for cardiovascular mortality. They showed a 50% reduction in cardiovascular death, right? Nothing does that. Statins are the most prescribed medication for cardiovascular disease. At best, statins can reduce cardiovascular mortality by somewhere around 24, 25%. 50% reduction in cardiovascular death by just taking 45 micrograms a day of vitamin K2. And here's the kicker, 25% reduction in all-cause mortality. People who had even minimal intake of vitamin K2 simply lived longer, right? They had a significant reduction in mortality from any other cause, in addition to cardiovascular disease. And you'll start to see why that is as we go through this particular lecture. But keep that in mind, that we're talking about osteoporosis, huge reductions there, a 6-fold increase in hip fractures if you have inadequate vitamin K2. In the case of cardiovascular disease, if you have even a minimal amount of intake of vitamin K2, you could reduce cardiovascular death by 50% and 25% all-cause mortality. That is massive, right? There's nothing that we have therapeutically, surgically, by a procedure that can reduce cardiovascular mortality by 50% like that. So that's massive. That's a huge thing. And there's no correlation for vitamin K1 in this study. So all of the vitamin K that's in your patient's multivitamins and so on has no impact on this at all. Because remember, and when you see vitamin K on the label of a multivitamin, it is vitamin K1. So it's there at the RDA levels of 90 to 120 micrograms a day. And it's there at that level just to prevent bleeding disorders. Here's another study. This is 16,057 women, right? These are not small nutrient studies. These are massive studies. This is, again, based on food intake of vitamin K2, 16,057 women between ages 49 to 70. Vitamin K2 intake was about 29 milligrams per day. And what they showed was with every 10 micrograms per day, increment of vitamin K2 intake, an inverse association between vitamin K2 and risk of CHD was observed. And a high intake of only menaquinones, especially MK7. Remember that distinction between MK7 and the shorter chain versions of vitamin K2, the MK4 I talked about earlier. But it's key with MK7, 8, and 9 could protect against CHD. So there's a dose dependency linear ratio here between your intake of vitamin K27 and your risk for coronary heart disease, right? Large study, lots of strong data. And here's the thing, I mentioned statins earlier. Statins are the #1 drug prescribed for heart disease. Statins inhibit the synthesis of vitamin K27, the cofactor for matrix GLA protein, right? Which in turn protects the arteries from which matrix GLA protein is supposed to protect the arteries from calcification. So statins can reduce cardiovascular risk by reducing cholesterol. So it's taking out one of the non-independent risk factors, but it is making one of the independent and the only independent risk factor worse, which in this case is the inactivation of the synthesis and recycling of vitamin K2 in the arteries itself. And so you cannot activate MGP, which means that you cannot prevent calcification of the arteries. So if you have patients on statins, they need it more than anyone else because the statins, you've put them on statins because they've already have risk for cardiovascular disease, whether it's family history, plus cholesterol or whatever the decision may be, but they are actually at an increased risk from the calcification standpoint because of the function of statins. Here's a couple other studies. In this case, they looked at 180 micrograms a day of MK7, minoquinone 7, on something called arterial stiffness in a double-blind placebo-controlled manner. And this is in postmenopausal women. Arterial stiffness is a huge issue because of the loss of arterial compliance. And what they showed is that long-term use of MK7 supplements improve arterial stiffness in healthy postmenopausal women, especially those that had really high degrees of stiffness. And at the end of the day, and there's a lot more, right? I don't want to belabor this point by showing you guys endless and endless slides of validation, but there's a lot more studies on K2 and cardiovascular disease. And there's, of course, a lot more in K2 and osteoporosis as well. But what I want to do that's really important in my book is to link these two, right? Because typically you wouldn't think that cardiovascular disease and osteoporosis are related in any way, but they absolutely are. Both of these conditions are absolutely connected. And the only molecular connection between the two, which can be observed and measured, is related to vitamin K2. So these were thought to be unrelated conditions, right? You've got a doctor managing your osteoporosis with a whole set of medications, and then you're managing cardiovascular disease with a whole set of other focuses and medications as well. No doctor would ever give their patient statin for osteoporosis, and no doctor would ever give a patient Fosamax for cardiovascular disease. Those are very different ways of managing patients, but these are absolutely related conditions with a singular risk factor that is teetering between both of these conditions. Studies indicate that the common factor may be the inactive metabolism and utilization of calcium. Think about it. In osteoporosis, you've got calcium not coming and sticking to the bone. In cardiovascular disease, you've got calcium sticking to the arteries instead. So it's a question of misdirected calcium. Calcium is supposed to be on the bone, not on the arteries. You've got MGP, a vitamin K27 dependent protein, in the arteries trying to ensure that the calcium doesn't end up on the arteries. And then you've got osteocalcin on the bone trying to ensure that the calcium ends up on the bone instead. And if vitamin K2 is not there present at adequate levels to activate both of these proteins, you're going to end up with calcium not on the bone, but in the arteries, and you're going to end up with both osteoporosis and cardiovascular disease. And in fact, there are strong correlations between the two. Men and women with cardiovascular disease and peripheral arterial disease tend to have lower areal and volumetric bone mineral density, as well as faster bone loss. And this is more specific to certain skeletal sites. And what they show is, on one hand, severe forms of cardiovascular disease like heart failure, myocardial infarction, hypertension, severe AAC are associated with higher risk of osteoporotic fractures, especially hip fractures, right? K2 dramatically reduces hip fractures by 6-fold. Cardiovascular disease goes along with significant risk for osteoporosis and hip fractures. And then, of course, osteoporosis and hip fractures go along with a higher risk of cardiovascular disease, as patients, for example, have a higher risk of cardiovascular disease. And what is the singular molecular connection between these two conditions? At least in the US, they're going to kill 30% of the adult. These are two of the top 4 or 5 biggest in North America. Both of these are connected through vitamin K2 and the misdirection of calcium. Now there is an issue because in the case of in the case of osteoporosis and now in cardiovascular disease as well, people are taking a lot of vitamin D. Vitamin D has kind of become the darling of the nutrition industry. And of course, vitamin D is very important. It's an essential nutrient. It does a lot of amazing things in the body. But when you have allopathic doctors out there prescribing and administering 50,000, 100,000 IUs of vitamin D every single day, because it's the only nutrient that they're familiar with, then we run into an issue that can actually make problems worse. And there is something called hypervitaminosis D, which is vitamin D toxicity. And in fact, there's a couple of studies that show, in this case, they're looking at the relationship between vitamin D, all-cause and cardiovascular disease mortality. What they showed was that there's a non-linear relationship to benefits of vitamin D for all-cause mortality and cardiovascular disease, meaning that it continues to go up to a certain point of intake. And when you reach a certain point of intake of vitamin D, the effects plateau or even decrease, right? And then there are studies like this as well. Studies like this as well, where they looked at regions where vitamin D deficiency was endemic. In this case, it's a region in Kashmir. And one of the things that doctors who visit these remote regions they've done is they see, okay, these individuals are really deficient in vitamin D. So they started giving these individuals high doses of vitamin D. And what they found when they came back after a year is as a number of these individuals presented with hypervitaminosis D. They found vitamin D toxicity to be quite prevalent among this population from taking all of that vitamin D supplementation. And the reason is they're not taking their vitamin K2, and I'll explain how K2 plays a role in hypervitaminosis D. The typical symptoms of this and the most prevalent symptom of this is hypercalcemia, right? So when you have hypervitaminosis D, meaning an overdose of toxicity in vitamin D, the most profound symptom is hypercalcemia, too much calcium in the blood. Again, calcium misdirection, right? And it can manifest itself in many ways: nausea, vomiting, excessive thirst, severe itching, joint muscle pain, disorientation, coma, and so on. And one of the reasons for this is vitamin D stimulates osteoblastic cells to release osteocalcin, undercarboxylated osteocalcin. So if you're taking lots of vitamin D, especially to help with bone, with osteoporosis, with bone health, you're going to be releasing a lot of undercarboxylated osteocalcin. Now that is going to require vitamin K2 in order to carboxylate it and activate it. So the release of undercarboxylated osteocalcin activates the function of vitamin K2. The problem is if you're taking a lot of vitamin D and no vitamin K2, and of course, like most of the world's population, you're getting very inadequate intake of vitamin K2 through diet, you have an imbalanced activation and demand for vitamin K2. So over time, when you continue to take high doses of vitamin D, what happens is all of your vitamin K2 stores get used up, and you actually end up with severe vitamin K2 deficiency, which leads to hypercalcemia, right? Remember, K2 is a singular nutrient that's responsible for putting calcium in the right place. So hypervitaminosis D presents with hypercalcemia. Vitamin K27 severe deficiency also prevents with hypercalcemia. So that's the key, right? If you're taking vitamin D or you're giving your patients vitamin D for bone health, for immune health, for cardiovascular health, whatever it may be, they need to be taking vitamin K27 with it. If not, all of that intake of vitamin D can actually increase your risk for cardiovascular disease and increase your risk for hypercalcemia because of vitamin K2 deficiency. Same thing that occurs in the arteries as well. Vitamin D can stimulate the release of MGP, but it requires vitamin K2 in order to activate it. So don't make the mistake of having your patients take vitamin D without vitamin K2. And a lot of people get a good amount of vitamin D, especially in sunny areas when they're out in the sun. So we need to make sure we are bringing up their intake of vitamin K2. K2 is also well known for its effects in diabetes and insulin resistance. Here's a couple of studies. And of course, this map is old. It's for 2003. But we know that the amount of diabetics and even scarier pre-diabetics is really mind-boggling across the world. I think by 2025 or 26, they predict that there'll be over 1 billion diabetics in the world, and there's almost 3 times that many pre-diabetics. So over the next 10, 15 years, most of those pre-diabetics will become diabetic, which becomes a huge issue because diabetes is a huge risk factor for other chronic conditions. However, vitamin K2 improves insulin sensitivity, and it does it through osteocalcin metabolism. Study published by the American Diabetic Association in this controlled trial manner. What they showed is they've demonstrated for the first time that vitamin K2 supplementation for 4 weeks increased insulin sensitivity in healthy young men, which seems to be related to increased COC, carboxylated osteocalcin, rather than modulation of inflammation. So as it turns out, osteocalcin, this protein that plays a role in sticking calcium to the bone and forming bone matrix, also seems to play a role in insulin resistance. And vitamin K2 is required in order to activate it for its role within insulin resistance as well. Now, they did say that although their study could not provide the underlying mechanism, they speculate that carboxylated osteocalcin or vitamin K could modulate adipokines or inflammatory pathways other than the interleukin-6 pathway. So there's a number of inflammatory pathways that vitamin K2 seems to be able to impact. And they say, alternatively, carboxylated OC can directly regulate glucose disposal at the skeletal muscle or adipose tissue, right? So carboxylated version of osteocalcin has an impact in the disposal of glucose through skeletal muscles and adipose tissue. It's fascinating because these are mechanisms that are not known right now, right? Who would have thought a bone-building protein plays a role in glucose metabolism? And a vitamin that is the critical component of activating that bone-building protein now has an impact on diabetes as well and insulin resistance. So like I said before, vitamin K2 is the omnipresent and omnipotent vitamin because it's present in all tissues, it's required in all tissues, and it's so powerful because it impacts some of the biggest chronic conditions that we face today. Just think about osteoporosis, cardiovascular disease, diabetes. If you just put all of those 3 together, that accounts for 70+% of adult mortality in North America, right? So it's massive. And there's other studies as well. Here's a study called the Prospective Cohort Dutch study, which is 38,000 patients aged 20 to 70. The setting was 918 incident cases of diabetes, just over 10-year follow-up period. They showed with each 10 microgram increment of metoquinone, that's K27, intake, that was a linear and an inverse association with the risk of type 2 diabetes. They also showed improvement in blood lipid profile, right? The same thing that statins would do. And the study shows that the intake of metoquinone reduces the risk of type 2 diabetes and helps in relieving insulin resistance. Remember that 10 microgram increment? Talking about that with regards to cardiovascular disease, same thing, same 10 microgram increment in a linear fashion reduces the risk for type 2 diabetes, right? So it's huge, it's significant. What else can do this? What other nutrient or drug out there in the market can do this, can have such an impact on both cardiovascular disease and diabetes at the same time? Both of which kill almost half of North American adults in a given year. Here's another study, and this is an ancillary study of a randomized double-blind control trial. This is 355 men and women, age 60 to 80, supplementing 500 micrograms a day of vitamin K for 36 months. What they showed that vitamin K supplementation for 36 months at doses attainable in the diet may reduce the progression of insulin resistance. Again, further affirmation of the impact of vitamin K2 in diabetes. And of course, like I showed you earlier, osteoporosis and cardiovascular disease are absolutely related, right? They affect different parts of the body. They present completely differently. They're treated completely differently. They're looked at completely differently, but they have a singular connecting factor, which is calcium misdirection, which is governed by vitamin K2 intake. And that's why vitamin K2 intake has such a huge impact on cardiovascular disease and osteoporosis. That same relationship exists for cardiovascular disease and diabetes with K2. Pre-diabetes is associated with risk for CVD death, right? If you had no diabetes, if you had perfectly fine glucose metabolism, if you look at this survival chart over, this was over a measure over 4 years, if you had no glucose intolerance at all, survival rate was really high among women. And then if you had any measure of glucose intolerance, including diabetes, the survival rate dramatically drops over time, right? So that's a measured for diabetes and cardiovascular disease that are tied together. And of course, this study showed, in the Journal of Cardiology in 2004, showed the prognostic value of coronary artery calcium screening in subjects with and without diabetes. Again, coronary artery calcium score is the only independent risk factor that is predictive of cardiovascular mortality. When you combine that with diabetes, you get a huge reduction in survival rate and a massive risk of death. If you look here, when you have low calcium, when you have no diabetes, survival is much higher. When you have diabetes, survival starts to go down, and it starts to change significantly with an increased risk of calcification, right? So diabetics will survive much better if calcification is low, and diabetics who have calcification have the worst outcomes of them all. And again, all of this is about misdirected calcium, activation of osteocalcin, activation of MGP, inflammatory cascades. All of these things are impacted by one nutrient, and that's vitamin K27. Most recently, the role of vitamin K27 in COVID has also been elucidated. A couple of studies have been published to show that COVID-19 mortality may be strongly associated with vitamin K2 status, right? This is really quite interesting. From this particular study, they showed that a accumulated risk of death stratified by DP, so that's the level of under carboxylated MGP, so inactive MGP levels, was created and found that mortality among COVID-19 patients appears to be strongly dependent on vitamin K2 status, right? And if you think about it, vitamin K2 reduces arterial stiffness, reduces inflammation in the arteries, and reduces calcification, right? One of the ways in which COVID increases death is by increasing the risk for thromboembolisms and thrombosis. And vitamin K27 in particular works against that. One of the ways it works against that is through another vitamin K2 dependent protein called protein S. Protein S is actually an anticoagulation protein working in soft tissue and in the arteries. And this study here, where they showed the link between vitamin K2 and COVID-19, the author suggests a vitamin K dependent endothelial protein S activation is also compromising COVID-19, which could lead to the tendency for clotting. Remember, this crazy hypercoagulation that occurs in people with COVID-19 was one of the things that was driving mortality, especially in the lung epithelia, and in some cases even driving strokes. And so they propose that insufficient activation of protein S in the blood vessel walls and MGP in the lungs, remember MGP is in all vascular tissue, so it's even there in the lungs, may lead to an increased risk for thrombosis and lung damage respectively. So not only is this vitamin so critical for heart disease, osteoporosis, diabetes. It's no surprise that it also protects against the most severe responses to COVID-19, right? It's an omnipotent, which all-powerful, omnipresent, all-present vitamin in the body. This is part of the reason why you see all-cause mortality going down as well, because vitamin K2 doesn't just protect against cardiovascular disease, it's protecting against diabetes, osteoporosis, infection, and so on, right? So it plays a significant role. Other proven clinical indications for vitamin K2, we talked about diabetes, but there's other studies like the Dutch population studies, which I showed you. But there's a number of studies on cancer as well. Here's one example study, a 23,000 patient study in Germany showed that higher intake of vitamin K2 was associated with lower likelihood of developing and dying of cancer. Again, another reason why all-cause mortality with vitamin K2 intake drops by 25%. It's helping with cancer as well. Vitamin K2 is shown to reduce prostate cancer risk by 35% in the EPIC study. It's called the EPIC Heidelberg Cohort study of 11,319 men taking part in this cohort study. 35% reduction in prostate cancer. And so, remember, I kept mentioning, keep in mind the all-cause mortality reduction. 50% reduction in cardiovascular death in the Rotterdam study, but the Rotterdam study also showed a 25% reduction in all-cause mortality because it's helping not only with cardiovascular disease, it's helping with osteoporosis, with diabetes, with cancer, with infection, inflammation, all of these things. This is a omnipotent, omnipresent vitamin. I couldn't think of a nutrient that does all of these things and protects against all of these types of chronic illnesses. Now, when we started looking at vitamin K2, because this has been a darling of mine as a nutrient for a long time, we wanted to understand what else does vitamin K2 do in the body, in particular because bacteria make vitamin K2, right? We know that in our bodies, vitamin K2 is activating things like osteocalcin and MGP. It's helping with bone health and cardiovascular health and insulin resistance and so on. But why do bacteria make vitamin K2? And bacteria make the richest forms of vitamin K2. Bacteria don't have bones, they don't have cardiovascular systems. So what are they using vitamin K2 for? And is that use by bacteria a use that we see in our bodies as well? That's the mentality that we had when we went into trying to discover what else vitamin K2 does in the body. And as we found, vitamin K2 functions in something called redox reactions. Remember, all of the activation stuff I talked about earlier with MGP, osteocalcin, and all that, those are carboxylation reactions. These are redox reactions. And this typically takes place in the mitochondria, and it functions in things like nerves and so on, right? So this was a proposal by a researcher in the 1950s where they talked about the redox cycling activity of vitamin K. It was proposed in the early 1950s. And then in 1960, a study came out that refuted this claim. And since the 1960s, nobody looked at it again because of one study that refuted the claim, and that study arguably was not done correctly. And so we revisited this area to see what else is vitamin K2 doing in the body. And of course, what's happening in the redox cycle in the mitochondria is vitamin K2 is playing a role in increasing the production of ATP, right? And this kind of ATP increase has a huge impact on all kinds of tissues. So you see here, the carboxylation reaction is supporting bone health, it's supporting cardiovascular health, but then the redox part of the K2 function is supporting nerve health, muscle health, and also cardiovascular health because the heart is a muscle. And so we'll talk about exactly how it's doing this, but keep in mind, ATP production, we use things like VO2 max and other measures, but vitamin K2 is playing a role in all of these tissues in a two-pronged approach, not just by activation of the proteins in carboxylation. So here is what my vitamin K2 is doing in the mitochondria itself. As you know, the mitochondria has these four main complexes, and there's something called the electron transport chain. Electrons have to be transported through this electron transport chain, and then the final electron acceptor, being oxygen, helps with ATP synthase, kicking off ATP from ADP. So the phosphorylation of ADP into ATP releases an energy molecule, right? CoQ10 is well known for playing a role in facilitating this electron transport chain. As it turns out, vitamin K2 also plays a significant role in the electron transport chain, in particular in complex 2 in the electron transport chain, thereby dramatically increasing the production of ATP in the mitochondria. So that is a huge area of study and a huge area of. So we started doing mitochondrial bioenergetic studies at Texas State University with Dr. Ted Reed, and this is one way to visualize mitochondrial bioenergetics, the function and efficiency of the mitochondria. And this is done in a machine called a seahorse machine, where you can study particular cells. In this case, this is a neuroblastoma cell, and we're looking at its mitochondrial respiration when you add in nutrients like vitamin K2. So here's what we see. When you measure this area, this is what we call the basal respiration rate of the mitochondria, right? So this is at rest. How much ATP is the mitochondria generating? Then you can add in a mitochondrial toxin like oligomycin, and then you drop down the ATP production to the base level. This is when you off ATP production, it drops all the way down. This is basically the basement level of ATP production. This is one of the lowest levels you can get from out of the mitochondria. And then you stimulate ATP production through a stimulant like FCCP, and then it drives it to your maximal respiratory capability, right? So it takes it from the basement level to the max, and then the difference between the basal level and the max is called the spare respiratory capacity. That's a really important component of mitochondrial health, because your spare respiratory capacity will dictate how your body responds to the world around you, right? That's the issue of sitting on the couch. Let's say you're sitting somewhere, you're resting, you are at a rested state, and then all of a sudden a danger shows up. You know, a lion walks into your room. Do you have enough spare respiratory capacity for your mitochondria to fire up enough ATP for your muscles to engage, your heart to engage, your neurons to engage, your eyesight to improve, your hearing to become more acute, so that you can jump up and sprint and run away from that danger, right? All of that requires a significant amount of spare respiratory capacity. And in my crude analogy, imagine two people sitting on that couch. A lion walks in. The one with the higher amount of spare respiratory capacity can engage his or her system, muscles, neurons, and so on faster and get out of that area than the person that has lower spare respiratory capacity. They would engage it slower, and they would likely be the one getting eaten, right? So that is an interesting measure of mitochondrial function. But what is shown is that with aging and with disease, spare respiratory capacity goes down, right? So we'll get into that a little bit more. But that is the way you measure mitochondrial bioenergetics. And so when we added vitamin K27 into a mitochondria, this is what we see. So this darker line here is the same energetics measurement after adding vitamin K2. And remember, this area right here is the spare respiratory capacity. And look at where it went, right? So remember, this is the basal rate here. And then this is the maximal rate. So the spare respiratory capacity in this case is this level right here. But once you add vitamin K2, look at the maximal rate of ATP production and look at the huge increase in spare respiratory capacity. So vitamin K2 plays a really important role in the function and efficiency of the mitochondria itself. It causes your mitochondria to produce more energy. without changing anything else, just the addition of vitamin K, vitamin K2 in particular, right? So this has a huge impact on nerve cells because there are numerous conditions that are driven by neurodegenerative pathologies. So as your nerve cells die, typically because the mitochondria in the nerve cells are dying, and we'll look at some of them. One of the ones that we kind of focused on was the ability of rescuing nerve cells from known degenerative conditions. And we saw this study back in 2012 from a Belgian researcher that looked at an animal model for Parkinson's disease, right? And what they were able to show is that using vitamin K27, they were able to reverse the neurodegeneration that occurs because of a PINK1 deficiency, which is the number one epigenetic deficiency that leads to Parkinson's disease. He said they were able to rescue the neurodegeneration that occurs due to mitochondrial dysfunction using vitamin K2. And this was in the Parkinson's disease model. So we said, that's extremely interesting. What else can we study that has neurological health involved and perhaps and we kind of focused in on mitochondrial conditions like neuropathy, peripheral neuropathy, right? So we zoomed in on peripheral neuropathy, which is a very common thing, and in this case, driven by B12 deficiency and or diabetes. And so we looked at individuals with peripheral neuropathy and wanted to see, could we improve peripheral neuropathy with 100 microgram a day dose for 8 weeks? And what we found was that when looking at the VAS score, we saw over an 80% reduction in the severity of neuropathy in a 4-week period, right? So again, neurodegenerative condition that affects neurological function and neurological mitochondria. With vitamin K27, you can see and observe a significant measured response within 4 weeks looking at neuropathy itself. And then, of course, multiple sclerosis, which is another neurodegenerative condition. Vitamin K2 in multiple sclerosis. This study concluded that vitamin K2 and K2 blocks 12 LOX activation and inhibits the accumulation of reactive oxygen species. So vitamin K2 does not directly inhibit the LOX enzyme activity when evaluated in purified LOX, suggesting that vitamin K prevents oxidative cell death indirectly by blocking the activation of 12 LOX and ROS generation. And they also conclude that MK4 or MK7 can suppress interleukin-6. This goes back to some of the diabetes studies on IL-6, and can suppress prostaglandin E2, which is one of the arachidonic acid pathway for generating inflammatory outcomes. So through lipooxygenase and cyclooxygenase, and by inhibiting COX. Therefore, these compounds can reduce inflammation and the consequences of autoimmune disease. So this is so significant, guys. Remember, we've already gone through osteoporosis, cardiovascular disease, diabetes, cancers, as I talked about in the Heidelberg Cohort study. And then we are starting to look at neuropathy and neurodegenerative conditions. And here's a study on autoimmune conditions, and in this case in MS, in multiple sclerosis, and the role of vitamin K2 in this disease. MS subjects had 1/4 the blood vitamin K2 levels compared to age-matched healthy cohort. Female patients had significantly lower vitamin K2 levels than males, and a decrease with age by approximately 10% per decade was found, right? So women really need intake of vitamin K2 adequately, and because they already have a significant disadvantage over men. We also find that vitamin K2 plays an important role in muscle health. And in this case, we're looking at in vitro studies on smooth muscle contraction and also looking at the heart muscle. What you find is that when you put in acetylcholine, which can increase or stimulate the contracting of the muscle, you actually show that vitamin K2 can release the contraction and smooth out the muscle activity. So it can actually release the cramping or the contraction of the muscle. And we were able to show this with barium chloride and histamine as well, 33% inhibition of histamine-induced contraction, and 30% inhibition of barium chloride-induced inhibition. So what we found is that in muscle cells, vitamin K2 provided the activation energy to be able to release the cramped muscle that is stuck in that contracted position, and actually allows for the relaxation of the muscle. And very importantly, we also showed that vitamin K2 did not inhibit the adrenaline-based contraction of the muscle, because that would be a negative outcome if the adrenaline-based contraction of the muscles was somehow inhibited by vitamin K2, but it's not, and this is quite clear as well. So we started studying things like muscle cramps, whether in elderly patients or in athletes, and we found that in muscle cramping, there was a huge reduction in people with idiopathic chronic muscle cramping. Often that's related to either a medication they're taking or a nutrient deficiency, but vitamin K2 significantly reduces the number of cramps and the severity of cramps every single day. And then when you remove vitamin K2, as you see here, then the severity and the number of cramps start to come back. So there is this dose dependency ratio as well, and you can cross over these patients, remove them from the treatment, and then you'll start to see the cramps coming back as well. Another area of cardiovascular disease or cardiovascular health that vitamin K2 plays in that's really important is cardiac output, right? This was a study this was an area we were very interested in, because we came to realize that vitamin K2 plays a very important role in muscle health, right? In the contractile function of muscle. Mitochondria, because of course muscle cells require functioning mitochondria provided with enough energy to contract and do the work that it does. The single most dense area of mitochondria formation in the body is in the heart, because the heart is a dense muscle. Every one of the muscle cells in the heart that make up the heart have high degrees of mitochondria. So our suspicion was that vitamin K2 would improve the function of the heart as a muscle, right? And it'll do that through improving mitochondrial function, and then of course, muscle contraction itself. So when we decided, okay, how do we study the improvement of muscle function from vitamin K2, we landed on cardiac output, because cardiac output measures the stroke volume times the heart rate. That's how much blood the heart is putting out with each beat. And so we said cardiac output may increase if you have a higher intake of vitamin K2. And what you find is that during exercise, and this is easily demonstrated through a number of studies, that high intensity exercise increase the fractional use of VO2 max and HR max, which causes a decrease in speed and performance, which means you're actually reducing your cardiac output over time as you're running. And part of that reason is because the heart as a muscle becomes tired, and the ATP production reduces over time. And so the heart itself cannot perform the way it should. And so they find that over a period of time, over the course of a race, athletes typically see about an 80% drop of the heart rate max, the rate at which the heart can function, and around 90% at the finish, at the end of the race. This heart rate increase was associated with a continuous speed decrease over time. So the heart is becoming less efficient as a muscle, and it's not functioning as well. And it also represents a decrease in stroke volume and overall cardiac output, right? So this is called cardiovascular drift in athletic training. And so this reported drop in stroke volume and cardiac output is a major limiting factor in exhaustive exercise. And so what we wanted to do was take people who are pretty athletic, these were college athletes, put them on K2 and measure their stroke volume and their cardiac output to see if vitamin K2 can reduce this cardiovascular drift that's seen even in trained athletes as the heart as a muscle becomes tired over time as it's working, right? And that's what we looked at. So this is a study that we were able to publish, I think back in 2016 or 17, where oral consumption of vitamin K2 for 8 weeks was associated with an increased maximal cardiac output during exercise. So not only did cardiac output not decrease when you got to maximal heart rate, it actually increased after the 8 weeks of supplementation. So Myomax was the K2 product that we use, which is vitamin K2 and calcium Pyruvate, there's only about 50 milligrams of calcium pyruvate. It's all 300 micrograms of vitamin K2. And what we saw was a 12% increase of cardiac output, which is significant because remember, cardiac output is per minute per liter of blood. So that's equivalent to about 60 liters of more blood in 1 hour of work, right? That's a huge increase in the amount of oxygenated blood that's pumping through and moving through the body in a single hour of work because of your increased cardiac output and stroke volume. And it said, and they concluded, the researchers concluded, without vitamin K2 supplementation, training induced changes in maximal cardiac output, meaning your ability to increase your cardiovascular function through training, could take 6 months of continuous training to achieve. So this 12% increase in cardiovascular performance would take 6 months of training to get to that. And we were able to do it in 8 weeks of K2 supplementation, right? So supplementing with vitamin K2 during training appeared to reduce this training window by 60%. So talk about the impact it has on your heart. Not only is it reducing calcification on the inside of your heart, on the vessels, but it's improving the heart as a muscle, and its ability to function. In fact, it's exercise in a pill in many ways, because the big benefit from cardiovascular training is increasing cardiac output and increasing and improving stroke volume. We are doing that with vitamin K2 by just taking the supplement, right? So it's so significant when you think about it. And this could be one of the most important anti-aging nutrients, because there are two main factors with aging, one called the mitochondrial free radical theory of aging. And it proposes that mitochondrial free radicals produced as a byproduct of normal metabolism and respiration causes oxidative stress. And according to the theory, the accumulation of this oxidative damage is the main driving force in the aging process. And this is especially true in cardiac mitochondria and the oxidation that occurs in cardiac mitochondria. And in fact, there was a revealing study published in 1998 where they looked at, where a team of pathology researchers looked at muscle tissue samples of a 90-year-old man, and they showed that it contained 95% damaged mitochondria compared to almost no damage in that of a 5-year-old. And that was the only difference they could discern between muscle tissue of a 90-year-old and a 5-year-old. The 90-year-old had almost 95% damaged mitochondria. The 5-year-old had almost no damaged mitochondria at all. That's the only difference in those two tissue samples, right? So if we can rescue the mitochondria, if we can increase the function and activation of the mitochondria, increase the spare respiratory capacity, increase the output of the mitochondria, we could reverse this driving aging factor in general. And of course, it's no surprise that cardiac output decreases with age, right? Studies indicate a decrease of cardiac output in aging and rest and with exercise. Substantially reduced output was a consistent finding in older subjects. So mitochondrial depletion of mitochondrial function, and then of course cardiac output reduction are all a major factor of aging. Vitamin K2 helps and works against that. Now, going back to the all-cause mortality reduction of 25%, it starts to become really clear why we would see a 25% reduction in all-cause mortality. K2 is helping with heart disease, with diabetes, with cancer, with neurological dysfunctions, with inflammation, with the function of your heart, and all the way to the function of your powerhouses within your cell, the mitochondria itself, right? So it becomes so easy to see how this is a omnipresent and omniscient vitamin. So looking at it in conclusion, we've got the carboxylation function and we've got the redox function of vitamin K2. The carboxylation function is absolutely critical for bone health, which means it's an osteocalcin activation, which is a factor both in osteoporosis and diabetes. We've got arterial calcification that it helps with by activating MGP, which is of course critical in cardiovascular health. We've got bone strength and formation, which is also a factor of osteocalcin, which is really important for oral health, because all of Weston A. Price's work was on the impact that vitamin K2 has on teeth and jaw development. So your teeth and the strength of your teeth, the bones in your teeth, that is dictated by vitamin K2 as well. And then, of course, inhibition of soft tissue calcification also plays a role in things like elastin and collagen function in your skin. So there's a beauty aging component to that as well. Then when you look at the redox function of vitamin K2, you've got an impact on the neurological and mitochondrial functions of the body. In neurodegenerative conditions such as MS, Parkinson's, neuropathy. You've got muscle mitochondria function, which plays a role in cardiovascular disease, in cramping, in cardiac output, which is age-related decrease in performance. And then, of course, you've got impact on IL-6 and reactive oxygen species, which plays a huge role in autoimmune conditions, age-related decline in cancers, diabetes, and so on. It is very hard to find a single nutrient that has this kind of global impact in the body, right? I cannot think of any other nutrient that has this direct kind of global impact on all of these conditions. And the scariest thing of it all is the Western population is subclinically deficient in vitamin K2. This absolutely critical nutrient, we get very little of it in our diet. So we're all deficient. So there's no surprise that the incidence of cardiovascular disease keeps going up. The incidence of osteoporosis keeps going up. The incidence of diabetes keeps going up. Cancers keep going up. All of these things that are vitamin K dependent or vitamin K2 dependent continue to increase because we are absolutely deficient. We're not getting adequate amounts in our diet. So this is the quintessential dietary supplement because it's so critical for so many systems and you have to get it through supplementation, right? So this is why I say that vitamin K2 is arguably my most favorite nutrient. It's omnipresent, it's omnipotent, and we need to take it as a supplement because we don't get adequate amounts of it in our diet, and it's needed for so many tissues in the body, right? And one of the things that's really important to remember, when your body is low on vitamin K in general, the body's design is to favor coagulation. And so vitamin K deficiency will also lead to hypercoagulable states because coagulation is favored. The activation of protein S, which is the anticoagulant, so you don't end up with thrombosis all over the place, is also dysfunctional. So one of the other measurements of vitamin K2 deficiency is disseminated intravascular coagulopathy as well. Right. So, and DIC is often misdiagnosed as DIC. And in fact, in many ways, it's a vitamin K2 deficiency. So hopefully this made sense. And thank you. I think I went over a little bit. Thank you for all of those that are hanging on, but I'm happy to hang on for a few more minutes to take any questions if there are any.
Thank you, Kiran. What a wonderful information and a lot. So I was thinking about, because I'm really concerned because here in Costa Rica, there are many doctors that use vitamin D in, for example, 200,000 units in a shot. And I'm really concerned about the calcium level in this person. We use in the clinic always vitamin D with K2, but I don't know if because we use in this K2, this vitamin D, we have 100 micrograms of K2. But I think always with person with osteoporosis that maybe they also have diabetes problems, is enough this quantity of K2 or we need to increase?
No, you absolutely need to increase. So when you look at the pharmacokinetic studies of vitamin K2, you get close to 90% carboxylated MGP and osteocalcin at 300 micrograms of K2. At 100 micrograms, you're somewhere around 40% activation of vitamin K dependent proteins. So there is a strong dose dependency ratio, especially if people are getting that much vitamin D. And in places like Costa Rica, you get a lot of sun as well. So you're going to be naturally making a bunch of vitamin D from the sun. So I would say people really absolutely need to take a minimum of 300 micrograms of vitamin K2. And I would actually, if someone's on taking 100,000 IU shot, 200,000 IU vitamin D shots, I would say they probably want to be in the 600 micrograms a day of K2, the level which you'd find in the Japanese food natto. In part because even if you're taking 300 micrograms, you may not absorb all of it because inflammation in the gut will inherently reduce K2 absorption. That's seen, for example, in celiac patients. Celiac patients, because of the enteropathy in the gut, have a dramatically reduced ability to absorb fat-soluble vitamins. So one of the factors of celiac patients is they present with brittle teeth, brittle bones, skin issues, and so on, because they can't absorb vitamin K, vitamin A, vitamin E very efficiently. So, so I would say, I would err on the side of taking a higher dose, especially if they're taking high dose vitamin D, and there's no toxic level for vitamin K2. We have done and published a number of tox studies where there's no LD50. I don't know if you're familiar with what LD50 is, but LD50 is lethal dose 50, which is where you take an animal model, you feed them high doses of the compound you're studying, you find the dose that kills the animal, and then you go 50% from that dose and you say that's the maximal exposure level. For K2, we have never found an LD50. We have fed mice and other animals 2,000 times the human dose, and no mortality, no dysfunction. So you can't go too high with vitamin K2. So I would err on the side of being higher than lower.
Okay. And when is the best time to take vitamin K2?
Yeah, that's a great question. So vitamin K27 has a half-life in the body of close to 72 hours. We normally recommend vitamin K2 taken BID. So you take one in the morning, one in the evening, and that maintains a high serum level of vitamin K2. Because what happens as soon as you take vitamin K2, the first place it goes is to the liver, right? So the liver takes all of fat-soluble vitamins into itself. And then depending on whether or not your liver has adequate amounts of vitamin K, K1 in particular, it'll release the K2 into the circulation. And so that process of going in and then ending up in circulation allows vitamin K2 over time to build up. And then if you take another dose in 12 hours, it keeps feeding that dose of vitamin K2. So you end up building a nice stable serum level. So, and we always recommend taking it with food. Vitamin K2 absorbs better with fat. So if you take it with a meal, you don't have to take it with a big amount of fat. Even a little bit of fat in the meal will do. So take it with food, take first one in sometime in the morning with your first meal, and then the second one sometime in the evening with your next meal.
And with the Myoma, it's better to take it after exercise or before?
You just take it with your meal, like normal K2. And then the benefits of it are, so the benefits of Myomax aren't related to that dose affecting that next bout of exercise, right? It's a long-term overall benefit because it's improving your cardiac output. So you just take it with your meals like you normally would every day, other supplements. And then what you'll see in about 5-6 weeks is a significant improvement in your cardiac output and your performance and so on. We have a lot of people, we have like a professional triathlete team in Chicago that uses it, a number of professional athletes in the people that do the endurance type of sports. They use it quite a bit, and you can tell the difference. You'll be able to tell if you're an active person, which I'm guessing you are, Patricia. If you run or bike or hike or whatever you may do, in about 3 to 4 weeks, you'll start to feel a difference. You'll go longer. You'll have more energy. You'll be able to last longer.
Okay, I will do it.
Yeah.
So, and what about people with atherosclerosis? Maybe these people, they are taking anticoagulants. It's safe to use K2?
Yes. So if you're taking anticoagulants, so it depends. If you're taking the old school anticoagulants, which are the vitamin K antagonists like warfarin, Coumadin, warfarin, you should measure your PTINR. But in fact, those people need it even more because of those compounds or vitamin K antagonists, they increase calcification quite dramatically in soft tissue. So there's actually 2 studies that show that 50 micrograms of vitamin K2 can actually stabilize your INR over time and not have it going up and down all throughout the day. So they would have to work with the doctor and over a 2-week period or so, measure and maintain your INR. And I think what you'll find is that vitamin K2 will actually help stabilize the INR and reduce that calcification. Now, of course, fortunately, there are new drugs that aren't vitamin K dependent, are not vitamin K antagonists, like I can't remember the names, Celebrex. No, maybe not Celebrex, but there's new drugs that are no longer working the way warfarin and Coumadin work, but they're not vitamin K antagonists. So with those, it doesn't matter.
Okay, and also because all these people also sometimes they have diabetes and they are taking statins, and so it's very important.
Yeah.
So can you explain, Kiran, what's the difference between Quinone and Myoma?
Yeah, absolutely. So really important. So Quinone is designed as your typical, what we would call gold standard K2 formula. The reason is, and the dose of K2 is the same in both, right? But in Quinone, we've added K1. The reason for that is because if you are somehow deficient in K1, the liver will hoard vitamin K2. It won't release all of the vitamin K2 into circulation. So, some people are still deficient in K1 because they don't eat enough leafy green vegetables and so on. And so we wanted to put the RDA level of K1 in there just to make sure the liver releases all of the K2. We also added magnesium in there and zinc, which are important cofactors for the carboxylation reaction that vitamin K2 facilitates, right? So if you're deficient in zinc and deficient in magnesium, you reduce the carboxylation reaction. So we wanted to make sure that if you're getting high levels of vitamin K2, then you should have enough magnesium, zinc, so that you can get all of the benefit from the vitamin K2. The Myomax doesn't have those other supportive ingredients. The Myomax is really for people who get enough of the other things, who get, we have a lot of people that say, oh, I get plenty of calcium, I get plenty of zinc from this, that, and the other, I get plenty of K1, and so I just want the K2. So those that just want the K2, then Myomax is the fit. But they have the same dose of K2 between the two of them. One has all those supportive ingredients. If you already have enough intake of the supportive ingredients, then Myomax is perfectly fine.
So for a person with osteoporosis, atherosclerosis is better than Quinone.
Absolutely. Yep. I think anyone aging, anyone with osteoporosis, any of the conditions we talked about that vitamin K2 plays a role in, Quinone is the key thing. We have a lot of people that are young, athletic, who already take a lot of other things, and they say, oh, I don't want the extra magnesium, I don't want the extra zinc. So we say, okay, just take the Myomax in so you get the K2. But most people use the Quinone. In the US, we probably sell 4 times as much Quinone as we do Myomax.
Okay, perfect. We have more questions with Dr. Karen, okay?
Yeah.
Thank you, Kiran, for all your information. You were
pleasure.
true. Now I love vitamin K.
Thank you.
Okay, so we have different questions from the participants.
Mm-hmm.
We have a patient that she's having well-controlled idiopathic purpura. Mm-hmm. She wants to know if she could take it safely.
Yeah, absolutely. I don't see any sort of contraindication with that at all.
Okay.
Yeah.
And if there is a relationship between decayed tooth and vitamin K deficiency.
Yes, absolutely. So in fact, that was the whole work of Weston A. Price, right? So Weston A. Price, and this was in the 1800s. He's a dentist, if you're not familiar with him. But he was doing all of this work on indigenous cultures that had really healthy teeth, really good jawlines, had all of their wisdom teeth coming in. As you know, in the Western world, most people have to get their wisdom teeth pulled out because their jaws don't develop adequately, and then they have very poor bone structure and high decay in the tooth. And what he found is that in those cultures that had really healthy teeth, they had really high intake of certain types of fat compounds, egg yolks in particular, and certain types of oils. And he isolated a compound from these oils that he called Activator X. He never identified it as vitamin K2, but he called it Activator X that had an impact on the tooth decay. It was later discovered that Activator X is actually vitamin K2 in these things. So absolutely plays a huge role in the health of your teeth.
Very interesting. Thank you.
Yeah.
If we talk about women's health, did you think that we could give it also as a menopause treatment when we start like giving vitamin D and calcium and everything? And also if it is safety to give it during pregnancy?
Yeah, it's safe, and it's absolutely important during pregnancy as well, because the initial doses of the fetus's vitamin K2, which is critical for neurological development, so brain development. There's studies on kids and neurological development, and then of course osteoporosis, bone development. Kids have 7 times the amount of osteocalcin than adults do, because they are growing. So in fact, kids need K2 even more. So it's important to start getting that vitamin K2 higher levels into your diet if you're growing a child inside you. And then it's absolutely important for your hip strength, your hip structures, and so on, for birthing, right? And then of course, managing inflammation like vitamin K2 does, managing glucose tolerance, because that, remember, is a huge thing. Diabetes in gestation is a massive issue, right? And certainly in the US, everyone gets measured for preeclampsia and other glucose intolerant issues during pregnancy. And so that becomes a really important factor as well. And then when kids are born, kids need vitamin K2. You could argue even 7 times more than adults do because of the growing bones. What was the second part of the question? That was the pregnancy one
and menopause.
Oh, menopause. Yes. Yeah, absolutely. So when you talk about calcium, for example, the British Journal of Medicine published a study in 2012, and they showed that for every 1,000 milligrams of calcium that postmenopausal women take, it increases cardiovascular disease by 2-fold. So for every 1 case of osteoporosis that it may help, it creates 2 cases of cardiovascular disease because of the issue of misdirected calcium, right? Calcium is a inert rock, if you will. It enters your system and floats around. And so if the women don't have adequate MGP activation, it's going to sit in the soft tissue, and if you don't have adequate osteocalcin, it's not going to make it into the bone. So that there's a huge impact on that. Just anecdotally, what we find with women who are postmenopausal or perimenopausal who take K2, of course, the bone, cardiovascular health, all those things they will realize. But the things that we get reported back is sleep, and we get reported back better energy, and then less impact on mood as well. One of the things we studied independently, which we haven't published this, but this is more an internal study, that vitamin K2 plays an important role in the sympathovagal tone, right? So that's in the activation of the sympathetic parasympathetic system. And vitamin K2 actually improves parasympathetic activation. So it plays a role in sleep and rest as well. That's something we're digging into a little bit more.
Thank you very much. Very interesting. As a last question, what will be a recommended dose ratio of vitamin D and vitamin K2 per day?
So I would say that you need a minimum of 300 micrograms of vitamin K2. So for every 5,000 IUs of vitamin D that you take, you need at least 300 micrograms of vitamin K2. That's going to be tough, and that's for normal maintenance, right? Now, if your doctor has you on 200,000 IUs of vitamin D, you won't be able to take enough K2 to maintain that ratio. But just if you're doing general supplementation, if you're taking, 4 to 5,000 IUs of vitamin D, make sure you get at least 300 micrograms of K2. Okay. If you're taking 10,000 plus, a lot of us in Chicago area, for example, in the winter, we take higher doses of vitamin D because of the lack of sunshine and lack of exposure to sunlight. So we'll take 10, 15, 20,000. That's a really important time to begin micrograms of vitamin K2. The good thing about vitamin K2 is it does build up in your system, maintain high levels throughout by taking it every day.
Okay, thank you very much for all your response and all the information that you gave us. We really appreciate it.
It's my pleasure.
Okay, see, I think we're finished with the questions.
Okay.
We have all, but we can answer.